When you dread a fall, how to survive?
Keeping my flag hoisted, Argentinian flag and Irish coloboma.
Inferior coloboma with a mature cataract intumescent in a young patient was faced. Like in all matured cataracts, the anterior capsule was stained with a blue dye and the excess dye washed off. The main entry wound was planned away from the coloboma. After putting viscoelastic sufficiently, we planned the rhexis with a cystitome. There was no free fluid, so we went on slowly but steadily along the margin of the rhexis marker. Usually in such cases, we are very skeptical because the cataract is intumescent, there's a chance of runaway rhexis, and secondly, there might be a subluxation in the inferior part as there is a coloboma. So I went very slowly and controlled fashion, always going back and pushing in a bit of extra viscoelastics to keep the anterior capsule flat and along the margin of the rhexis marker that I have already done. But as I came towards the position of the coloboma, I noticed that it was not possible to rotate the flap, and very soon I developed a runaway rhexis exactly in the point where there was the coloboma. Before I could realize anything, it started stretching and I had an Argentinian flag sign. Now all seemed lost and I was about to drown. But I did not lose hope. I went in with microrhexis forceps, tried to retract that flap and with a jerk to pull it towards the center, but I failed. So now I had to plan differently, so I made 2 incisions on either side with the side port, and then with microrhexis scissors I cut at the point where it had run off, and then with the microrhexis forceps I tried to turn that. I had to repeat the cut again along the edge of the runaway rhexis. I was repeatedly using the viscoelastic. Making the entry wound, I used rhexis forceps to finally pull the end part of the rhexis towards the center, but I noticed a small tag. So again I went in, tried to turn it again towards the center and make the rhexis a bit regular, but I still had a small tag which was giving me a bit of headache how it would react when I would do a phaco. I did not do hydrodissection or delineation. I used dispersive viscoelastics and went in with phaco. My phaco power was down, my irrigation was very low, and in a very controlled fashion I did a central shaving. I tried to make a trench. The center part was deep. And then I cracked the nucleus manually, keeping all parameters down and minus rise. I lifted the nucleus in foot position 2 with vacuum from the bag and put it just above the rhexis margin. Low bottle height, controlled vacuum and a lot of viscoelastics to push back the posterior capsule. Slowly but steadily I emulsified the nucleus by chopping it. I used more of this blunt second instrument to help me do so. I was using a lot of my second instrument to bring the pieces to the tip of the phaco probe so that it did not go and injure the rhexis margin or hold the tag. Before withdrawing the probe, I refilled the anterior chamber with viscoelastic to avoid collapse of the anterior chamber. An unstable anterior chamber might lead to complication here. I tried to bring the pieces towards the tip of the phaco probe so that I did not have to go fishing. With the help of the second instrument, I kept the tags away, and with very low parameters, I slowly ate up the rest of the nucleus bit by bit, keeping the phaco probe in the center and emulsifying it under direct visualization, and using more of my blunt second instrument to bring it towards the phaco tip, as well as putting it below the tip to keep the PC and the flaps away from the probe. Very soon I completed the nucleus removal and very little epinucleus that was left. A controlled fluidics with low vacuum, less irrigation, controlled phaco power went a long way in maintaining the anterior chamber and controlled phaco emulsification in closed chamber to save my case. I maintained the AC again with viscoelastic before withdrawing the probe. I used a multi-piece ION after putting a lot of viscoelastics, and everything looked much better, and the surgery looked completely under control. I dialed the trailing haptic slowly but steadily and did an optic capture by putting the haptics over the rhexis margin. I used pilocarpine after washing away all the extra viscoelastics that I had been using to keep my anterior chamber stable, and the eye looked quite good. I cut off the small tag that was there, and there was a complete control over the case.
Thus my flag stayed hoisted, I stayed afloat.
With a lot of patience and good fluidics, thus I could handle such a case successfully, and the patient gave very good vision post-operatively. Thank you for watching.